Now, another barrier is, because of the dropout rate, we're saying we need to target people in school, right? But if the dropout rate is high, and those are the ones that might be at higher risk, how are we going to target them?
What do you guys think?
Get them when they're younger.
Yeah, it's get them when they're younger, when they're not even thinking of dropping out, when it's not even a consideration. So again, we go back to the middle schools, right? Or middle or elementary. Yeah, that's true. Or elementary. Well, actually, I think communication needs to start definitely in elementary, addressing just communication in general.
Yes.
But I just wonder, you know, to me, I know we're talking about Latinas, but I just really think that there's probably a lot of Latino, boys who have attempted or thought, but because we see only like the rage, the anger, and so they're dropping out of school because maybe they're always getting in trouble. You know, all these things are happening, and really it's because they are feeling suicide, but they don't want to say that. You know. And another thing is that when we, I work in the school district, and so when we have kids that have said they wanted to hurt themselves, and we see the behaviors at school, and then we say we need to be evaluated, we tell the parent, you need to take them to be evaluated at a crisis center. And when the kids get there, the parent is already saying, look at all of this, we don't have money. And then when the therapist or the crisis person interviews that student, they say, no, I don't really want to hurt myself. But we at the campus or in the school district see the behaviors that do indicate that they are suicidal. But, the crisis unit has to go based on the interview.
Yes, and that's one of the difficulties that we run into when evaluating kids. Because when a child is evaluated in the ER, it's more of the here and now, right? If the physicians are not necessarily in tune to the fact that the here and now doesn't necessarily mean anything for kids, right? Then a lot of kids can be let go that have a high risk and actually need hospitalization. So when you think about hospitalization, it's about safety. And safety isn't only about, I want to hurt myself right now. It's about, I've been hurting myself more and more and more for the past week. I don't have a very good support system, right? And I'm saying this as in we're evaluating, they don't have a good support system. They don't have good communication with the parents. So once they leave the ER, it's very likely that something's going to happen. But you're completely right. The other thing is, because the system is so difficult to get into, people are very much discouraged. Once you're waiting in the ER for 6 hours, why would you even want to hurt yourself? You're going through that pain anyway, right? By the end of that, you're exhausted. I want to go home and sleep and eat, right? And suicidal ideation, we have to understand, are fleeting thoughts sometimes. They are not there constantly. Sometimes the kids still have some ability to enjoy themselves. And they're watching a good movie, they're not thinking about it. And it won't happen again, the thought doesn't happen again until they get into that argument because they want to text at 11 o'clock at night and the parents say, no, you can't use your cell phone. And then all this anger and irritability come up and they go, oh yeah, I was thinking about hurting myself, right? So we can't always think that unless they're thinking about it all the time, it's going to be a risk. It's more of a risk when it's like sporadic because you never know when it's going to come up and they're going to do something. Okay. Any more questions or comments? Yes.
The budget cuts will have an impact on people getting service, wages, and our gas.
Yeah. Well, supposedly the insurance, providing the insurance for the kids is going to increase, supposedly. So we need to see that, but I'm not sure. No, that's horrible. Yeah. The other thing that we have with the limitations is that we still do have limitations for the time of hospitalization, right? So I might say, I need 10 days for this kiddo. But they're not going to be insured for that amount of time, right? So we can't provide we can because we're a non-for-profit and we have that ability, but that's not going to necessarily happen in every place. You run out of days and you run out of days, or you run out of criteria, right, then you have to discharge the patient, or else it's going to be out of pocket for the parents. Yes.
I just wanted to comment on a couple slides back when you said family therapy, because so many kids that are brought in to, especially if it's the stigma of the psychiatrist's office, are in their head thinking, well, my mom and dad do the same thing. So they yell and they scream and they have the fits and they just do it in the adult ways. And so they're like, why am I the one? You know, and yet they don't feel the freedom to call out their parents because it's their parents. Or they don't feel the freedom to call out their whole family because it's endemic throughout the family. The coping skills that develop in the family of, you know, maladaptive coping skills are throughout the whole family. But yet this one kid got to a point where it was so bad that they get labeled as a problem.
And that's, yes, and I think that's what's important also for the Latino population is to have family therapy, because then you can't, you're less likely, or the kids are less likely, as well as the parents, you have to work on it, but less likely to do the blame game. You know, you're the cause of this, and so you're the one that gets all the treatment, and we have to come here every week, once a week, and spend 3 hours or 4 hours to talk for an hour because of you, right? And so the idea is, it's the whole family here we're working on. So it's for everyone, it's not for just one individual. And some kids don't want to talk on an individual basis. They feel much better when you start the therapy with the parents first, and then you have them come in, and then you have the siblings come in. So I think the family therapy or the group approach is much easier.
And I think families are afraid that, to hear family therapy, oh my goodness, they're going to tell us we're horrible parents. You know, and trying to, you know, just talk about we're all coming together to help this child, and it takes all of us working as a team in order to help. Because, you know, in our work, we find that if you say family therapy, you know, they want to back off.
Oh, that's true. That's true also. And it is a very scary thing. I mean, for everyone, it doesn't even really matter what cultural group you're in, you know. You know you're gonna hear that it's about you anyway, you know, about the mom or the dad, and they need to do something. And the truth is, the primary obligation, right, responsibility is in supposedly the adult that can process much better. But again, there's maladaptive coping skills, so that's not necessarily the truth. But it is the parent's responsibility, or else it would be medical neglect if they don't pursue.
Do you find that with so many very young parents, and now their children are getting into adolescence, and the parent themselves are very young and lacking skills, do you come across that in your work, in your practice? Because we're finding it, you know, we have a lot of little bitty ones that are like 3 and 4 year olds that are having a lot of difficulties in school. The behaviors are really outrageous, and the parents are very young. The parents are like, you know, 18, 19, you know, years old, and you know, it's, you know, I'm wondering if you're seeing that in your practice.
You do, because we have this I think, a misconcept that adulthood starts at 18, right? And I think that a lot of people are still working on it at their 20s, 30s, and 40s. And it really depends a lot on coping skills and being able to pass that on and have the responsibility of kids on top of that, right? Like younger children, your own kiddos. Yes, I think that makes a big, huge difference. Is that, again, we saw that Hispanic girls have the highest pregnancy rate. And so we have a lot of young girls that are not independent in the sense of being able to make decisions on their own, or have the coping skills to handle, you know, and they're single on top of that, so their support group is kind of limited. And then there's a lot of rejection of single, young Hispanic girls because they got into the trouble they got. And it's always the girl's fault anyway, right? It's never the guys. Like, they didn't do anything. It's too cool for the guys. It's not cool for the girls, right? So yes, I think there's a lot of kids trying to raise kids. And for adults, think about it. Everyone that's had an experience raising a child, they could be completely without any mental health issue, have a great IQ, and there are moments where you just want to pull your hair out, right? So it's a challenge.
Do you have any suggestions on how to encourage the mothers to come to settings? So the years I've worked with adolescents in this kind of population, I have found, this is a generalization, that the mothers will come in with their adolescent sons, but they tend not to come in with their adolescent daughters. And I don't know what that's about.
Because there's no conflict.
Well, yes.
Right?
How, I do know that making that contact with the mother helps when they hear my voice, so basically hear my voice and encourage them to come in. But it is very rare to get that mother engaged in the house session.
I think there's, one of the things that comes to mind when you mention that is that I think a very distinct cultural difference between, for example, the Hispanic population and more of the Anglo population, or individuals that have grown up here, is that individuals that have grown up here want a here and now solution to things, right? So they come and see you or see me as a psychiatrist, and they do want to hear in 1 hour, this is the diagnosis, this is the medication I recommend, and this is what we're going to do, right? Most of the Hispanics that come into the office, if I jump to say, this is the medication that I recommend, then how is it that in 1 hour you're going to tell me what all this problem was and come to this conclusion? It's impossible, right? They want to establish, relationship is very important. So they want to establish a relationship first. And it can take weeks, months, and even years. I've had patients that will not take medication, and they need it, but we worked for a year until finally they come and say, okay, now I really think I need to take it, right? Or the parents finally, but it doesn't mean we've lost a whole year of treatment. On the contrary, it's a whole year of treatment, establishing the rapport and establishing a relationship to the point that they are feeling secure, right? But we also want a quick fix. And so being able to do that for a year or 6 months can be, can be difficult. I mean, that can work like, okay, I know you keep on coming in, you keep on telling me you have this problem, but you're not following my recommendations, or, it's frustrating kind of thing. So my answer to you is, if it's almost like you have to establish a relationship with the mother, right, to get to the point where they trust you enough, and that's going to take who knows how many visits or encounters before you can say to them, you know what, I really need for you to bring your daughter in, kind of thing. There's also this concept in general of protectiveness over the daughter more so than the guy, right? A teenage guy, the Latino mom tends to think that, they're pampering, right? And he's still mommy's boy. But they tend to feel, I believe, that they have more individuality, they're able to make their own decisions, right? So that they're safer. Because he's going to be able to say whether he wants this treatment or not. My daughter's a little bit more vulnerable. So I'm not necessarily they don't feel as safe bringing the daughters in. And then we have the conflict. The communication in general, I think there's less, and this is general across the board like you mentioned, there's more of that stress between the adolescent female and their mom at that time. So the guy might feel like he can be quieter and it's easier to bring him in. He's just going to do what mom says and then go and do whatever he wants to do. It's a different attitude. So it's all about relationship. Yeah. Which is hard in schools because they're moving on from one grade level to another, and then you kind of lose them. Okay. Well, if there are no more questions or comments, thank you very much for joining us. Really appreciate it.